gentlemen, we're delighted to introduce our first keynote speaker today. It's Dr. Terry Lynch. He's a Limerick man. He's a medical doctor of 30 plus years. He's also a psychotherapist. He's an author of the much acclaimed Beyond Prozac and Selfhood. Dr. Ivor Brown, in description of Terry, said, "Would that there were more enlightened doctors and psychiatrists like Dr. Lynch working in the country." It's a great honour to have him. It's very exciting for us. Ladies and gentlemen, Dr. Terry Lynch.
Thanks very much. It's a real pleasure and honour for me to be here. Technology is not my thing, so I just need a little bit of help here for a second. It really is a pleasure and an honour for me to be here today, and I'm very happy to have been asked. Thank you for asking me. I'm working as a doctor for over 30 years, I guess, and I've been aware of the Samaritans for a long time. And you know, you're a wonderful organisation. The work you do, I don't think you have a sense, probably, really, of what you mean to people. I think that I've gone off track already. You know, I use overheads to keep me on track, and I'm already gone. But I think a lot of the work you do is at the end of the phone, and I think that perhaps you don't always get a sense of what you mean to the person at the other end of the phone. And I know over the years that you mean a great deal to other people, the people you work with. So, I'm trying to stick to the theme, which is the power of listening, which is a great theme. So just briefly about me, I qualified in 1982, and I worked as a GP between 1987 and 2000. At that point then I did an MA in Humanistic and Integrative Psychotherapy, and from then on, from about 2000 onwards, I worked as both a medical doctor and a psychotherapist, really, providing what is probably best termed a recovery-oriented mental health service from about 2000 to now. I'm also, as John mentioned, I'm an author of a number of books, Beyond Prozac, Selfhood. My next book will be available in about 4 or 5 months, and the title is Depression Delusion, Volume 1, The Myth of the Brain Chemical Balance. Now, the intention of the title, the experiences and behaviours that are characteristic of depression, they are very, very real. What I've learned over the years is that there is a lot of misinformation in this whole area of mental health. And the whole chemical imbalance idea, which has gripped the world really and is one of the most dominant ideas in mental health, is actually without any scientific basis. Anyway, that's not for today, but that's what I'm working on at the moment. So, the power of listening. As I reflected on this talk and on my presentation today, I was struck by just how much a part listening has played in my life and in the changes I've made in my working life. So here are some of them. I qualified as a doctor in 1982. That slide's slightly wrong. I'm 2 years older than that slide says. And I trained to be a GP, and I worked as a GP for 10 years. And I guess we're always listening to something, really. And as I reflected, I realized that what I was listening to primarily for the first 10 years of my working life as a doctor was my training. That was what informed me more than anything else. And I listened to my patients through the lens, if you like, of my medical training in those years. But between about 1987 and 2002, I began to change somewhat, and I was increasingly struck more by the validity of people's stories and less by the medical interpretation of people's stories. It was at that point that I went about doing the MA in psychotherapy, and this resulted eventually in me ceasing working as a general practitioner because I felt I needed to work in a more meaningful way for myself particularly. And I commenced the recovery-oriented mental health service in Limerick, which is attended by people from all over Ireland and from beyond Ireland as well. And my listening also was a huge factor, I suppose, in writing Beyond Prozac, because that was the result of my listening. My listening to people, my listening to what I was hearing from within my profession, and my listening to what people outside the profession were saying. So, listening and acting upon the learnings from the listening progressively increased my understanding of people in distress. I've no doubt about that. And it's been a progressive journey of growth in understanding and awareness, mainly through listening. It can be hard sometimes to really listen in this way, because if you listen very carefully to what people are saying and what people need, it can have implications for what you do yourself. And this is what kind of happened to me. as the years passed. And the more we listen, quite often we're invited by the listening to change, to give up perhaps and make changes, and this can be quite challenging for us. So one can understand perhaps why people struggle to really listen very well. Dorothy Rowe, some of you might have heard of her, she's a British psychologist and author of many books. She wrote the foreword to the British edition of Beyond Prozac, and again the listening comes up in one of the things she wrote actually she made this comment in her book, Depression, the Way Out of Your Prison, but again it was about listening. Terry Lynch listened to his patients, and so he came to see that there were direct connections between the form of the patient's distress and the life of the patient. And that really does sum it up. I began to realize that distress makes sense, and that we can make sense of it by listening very carefully and being guided by the listening. I think this is an important slide. I've learned very carefully by listening that core issues in emotional and mental ill health, what we would call mental and emotional ill health and distress, including suicide and suicidality, are woundedness or trauma, pain, distress and unhappiness in its many forms, defense mechanisms that we create in response to the woundedness and the pain and distress, and then the choices that we make, how we use our free will. And when we're very distressed, the previous three I mentioned affect the types of choices we feel open to us. Woundedness and trauma are much more common than generally realized within society. And as with physical woundedness and trauma, the degree of emotional and psychological pain and distress reflects the degree of emotional and psychological woundedness and trauma. Woundedness and distress, they're very personal, very individual. What hurts one person may not hurt another, and vice versa. And, within society there is quite a lot of sympathy or response to people, say, who have had a big thing happen in their life. But for a lot of people, it's the accumulation, like the silent, unseen accumulation of woundedness over time that isn't seen really. And so much hurt goes unseen, unheard, unnoticed, and therefore unresolved in our society. These are two quotes from two psychiatrists that I've had a great deal of respect for. Ivor Brown, in his book Music and Madness, described the slings and arrows of life. The late Michael Corrie and Anya Tubridy, a great psychiatrist, and his wife is a doctor and psychotherapist, put it very well in their book, Depression is an Emotion, Not a Disease. Life fired at you point blank. And the majority of people who ring you, I suspect, have felt life fired at them point blank. So woundedness and trauma causes pain and distress, emotional and psychological pain and distress in various forms, including the following: emotional pain and hurt, loss, sadness, loneliness, grief, rejection, abandonment, helplessness, pain from change and fear of change, fear, anger, terror, overwhelm. These experiences are common for many people in life. Stigma. We talk about stigma, and the question is often asked, is there a major stigma around mental health and mental illness? And the clear answer to that is yes. But I would say yes, but. And the reason I say that is that is not the primary stigma. The primary stigma is deeper. And the primary stigma is the stigmatization of human experience and behavior. That's the primary stigma. And when there is stigma, people do not listen. People do not hear, they do not accept, and they do not validate. And that has the opposite effect of good listening. And that effect is just as profound as the effect of good listening. So in our societies, Ireland, Britain, most Western societies, so-called developed societies, there is great stigma and censorship of many human experiences and behaviors, such as crying, grieving, shaking with fear and anxiety. How many places is it okay to be shaking with fear and anxiety? Feeling insecure, scared, lost, overwhelmed, and of course, feeling and being suicidal. But the problem is, if we censor in our society, if we censor the feelings and their expression, we inevitably censor the person. And where does that person have to go then? Where can they go? Where can a person say, I can't go on, I can't take it anymore, I feel suicidal, I want to end it all? I want to kill myself, and be listened to, patiently, respectfully, fully. Unfortunately, there are very, very few places in our society. But you, the Samaritans, you are one of those places. And it's an extremely important function you provide in society. As we well know, a problem shared is a problem halved. And that's what you are doing. You are helping to reduce the intensity of problems and pain by allowing the pain to be shared with you. And through listening, I have learned and seen the transformative effect of real, true, honest contact between two human beings. I've witnessed many people work their way through feeling suicidal, through tears, sorrow, sadness, and loss, and attain some relief by working, and often a great deal of relief, by working through their emotions and truly expressing themselves. You may have heard of Carl Rogers. He's a very famous therapist in America, founder of person-centered therapy, and this is what he had to say about being listened to and heard. When a person realizes he has been deeply heard, his eyes moisten. I think in some real sense he's weeping for joy. It is as though he were saying, "Thank God, somebody heard me. Somebody knows what it's like to be me." And this is a reaction I get fairly frequently from people. The reaction, "Oh my God, you get me. You understand me." Again, the immense power of listening, and listening well. Carl Rogers also said about himself, "When I have been listened to and heard, I am able to re-perceive my world in a new way and go on. It is astonishing how elements that seem insoluble become soluble when someone listens. How confusions that seem irremediable turn into relatively clear flowing streams when one is heard. I have deeply appreciated the times when I have experienced this sensitive, empathic, concentrated listening. That is the potential you bring to every interaction you have with people." So then what's the power or the effect of not being heard? I guess, expectedly really, it's the opposite of all of the above. When people don't feel heard or listened to, which is very common in our societies when people are in distress, that causes increased woundedness, increased hurt, pain, distress, sorrow, loneliness, rejection, abandonment, and loss. And that leads to increased withdrawal, shutdown, hopelessness, depression, isolation, and disconnection. And ultimately, unfortunately, tragically, commonly enough, to increase suicidality. Stephen Covey, the author of 7 Habits of Highly Successful People, some of you may have heard of him, it's a very well-known book, very good book, once wrote that most people do not listen with the intent to understand. They listen with the intent to reply. And quite often when you're talking to people, you can see that in their faces. They're actually formulating their response before you've finished speaking. And that is not high-quality listening. Ernest Hemingway once said, "When people talk, listen completely. Most people never listen." And as I saw this, I wondered, did that reflect his own experience of life? As many of you may know, he took his own life. But you and the Samaritans, this is based on my contact with people who have been in contact with you. You have learned to listen well. And therefore the power and potential of listening can come to fruition in what you do. Many of those attending me are at times in great distress, and many have occasional or regular contact with the Samaritans. I regularly get very positive feedback from clients regarding their contact with the Samaritans. It's very regular that I get that. And it seems to me that the Samaritans exemplify key aspects of what people in great distress need. They need acceptance, they need time, they need gentleness, they need safety and to feel safe in the conversation, non-judgment, they need patience and respect. They need high-quality listening and little or no advice. And within the Samaritans, I think one of the key themes really is that there is no censorship of expression from the listener. And this is quite uncommon in modern day society. And in this type of therapeutic engagement, the person is facilitated to express themselves in ways they may never have before. And this high quality listening gently invites the person to talk and work through emotional distress hear themselves speak of it, which you could call self-listening. And that's very important, that the person actually hears themselves talk their way through it. And to have their distress and story listened to and witnessed respectfully. And in providing exceptional high-quality listening like this, the Samaritans bucked the trend. You buck the trend of what passes for listening in society. That's very important. Consequently, the Samaritans play a crucial role for people in major emotional and psychological distress. A question I wonder sometimes, how many lives have been saved as a consequence of the Samaritans and the work you do? I'm not sure if anybody knows that figure, but I've no doubt, I would guesstimate that's many, many, many lives. Aspects of the Samaritans reflect also, I think, how emotional and psychological distress is viewed and dealt with by perhaps the majority of people in society. Most people, I think, see the Samaritans as important, as needed, and most people really respect what the Samaritans do, what you do. But I think for many people, the Samaritans are kind of out there somewhere, doing what they do. An almost invisible, though important presence in any community. Playing a vital role in the community, and people are very happy to donate and help out. Yet many people don't really engage, I think, directly with the Samaritans. And I think that may be a reflection, really, of how we approach emotional and psychological distress. It's like invisible also, almost a secret, but present, just like our emotional and psychological distress. John Waters, a very well-known Irish journalist, when Beyond Prozac was published, he wrote in the Irish Times that he felt, because a third of that book was about suicide, and he wrote that in his opinion the book was the single most important contribution to our understanding of suicide in the past 10 years, a vital articulation of the unsayable. Now, while I was very happy he said the first bit of that, what really struck me was the second bit, a vital articulation of the unsayable. I think that is put very eloquently. And it makes me think, what is it that's unsayable in our society? And it comes back to some of the stuff I touched earlier. Because what is unsayable in our society, unspeakable, is our emotional pain and hurt, our losses and sadnesses, loneliness, grief, rejection, abandonment, helplessness, our reactions to change and our fear of change, fear in general, terror, anger, overwhelm. These experiences are so common, as I said earlier, for many people in life, yet there isn't free expression of these things within our society. What else is unsayable? Well, human experiences, like I said earlier, behaviors like crying, grieving, shaking, trembling, feeling insecure, scared, lost, overwhelmed, and of course, feeling and being suicidal. And as I said earlier, if you censor the experiences of that people are having and the behaviors that they express due to how they're feeling, then you censor the person. And in my opinion, that is going on in our societies every day to thousands of people. And this is why I put it up, really. You and the Samaritans, you listen to the unsayable. And in this interaction, the unsayable becomes sayable. It becomes said, listened to, heard, shared, halved. The unspeakable becomes normalized. And the more practiced we become at listening well, the better we become also at hearing both what people are saying and what they are not saying, what they have learned to hide or suppress. And that brings me to my favourite poem, which I'd like to read to you. And it's called The Power of Listening. Or sorry, it's not. It's called, that's me. Yeah. My talk is called The Power of Listening. It's called Please Hear What I'm Not Saying. And I came across it by Charles Finn. I came across it in a great book called Healing the Child Within, which many of you may know by Canadian Dr. Charles Whitfield. And I love it because it's real and it's honest, and it portrays the human inner world and struggle, and the longing to be understood and accepted as we are, that I think we all share, but particularly people who are profoundly suicidal, deeply suicidal, really experience. And those experiences so seldom get listened to well, but that is the kind of listening that Samaritans do very well. So, here's my favourite point. Don't be fooled by me. Please don't be fooled by the face I wear. For I wear a mask, 1,000 masks. Masks that I'm afraid to take off, and none of them are me. Pretending is an art that's second nature to me. But don't be fooled. For God's sake, don't be fooled. I give you the impression that I'm secure, that all is sunny and unruffled with me, within as well as without. That confidence is my game and coolness my name, that the water is calm and I'm in command, and that I need no one. But don't believe me, please. My surface may seem smooth, but my surface is my mask, my ever-varying and ever-concealing mask. Beneath dwells the real me. In confusion, in fear, in aloneness, but I hide this. I don't want anyone to know it. I panic at the thought of my weakness and fear of being exposed. That's why I frantically create a mask to hide behind, a nonchalant, sophisticated facade to help me to pretend, to shield me from the glance that knows. But such a glance is precisely my salvation, my only salvation, and I know it. But you've got to help me. You've got to hold out your hand, even when that's the last thing I seem to want or need. Only you can wipe away from my eyes the blank stare of the living dead. Only you can call me to aliveness. Each time you are kind and gentle and encouraging. Each time you try to understand because you really care. My heart begins to grow wings. Very feeble wings, but wings. With your sensitivity and sympathy and your power of understanding, you can breathe life into me. And I want you to know that. I want you to know how important you are to me, how you can be a creator of the person that is me, if you choose to. Please choose to. You alone can break down the wall behind which I tremble. You alone can release me from my shadow world of panic and uncertainty. You alone can release me from my lonely prison, so do not pass me by. It will not be easy for you. A long conviction of worthlessness builds strong walls. The nearer you approach me, the blinder I may strike back. It's irrational, but despite what the books say about humans, I am irrational. I fight against the very thing I cry out for. But I am told that love is stronger than strong walls, and in this lies my hope, my only hope. Please try to beat down these walls with firm but gentle hands. Who am I, you may wonder? I am someone you know very well, for I am every man you meet, and I am every woman you meet. That's some poem. The only thing I think I would perhaps add to that is, in my experience, such behaviour is not irrational. Irrational is not a word I particularly like because it sort of dismisses the validity of the feeling or the experience. And I've learned over the years, again, through listening carefully, I've come to realise that a comment like that, for example, that I fight against the very thing that I cry out for, makes perfect sense. I may indeed want this contact, crave it, cry out for it, but it may terrify me so much that I may see my greater need as ensuring that I do not go there. Many of us greatly fear the peak intensity of our own emotions. This is a recurring theme in the work I do. That's such a fear for us, the peak intensity of our grief, the peak intensity of our pain. And we run from that because in society there aren't pathways or well-known pathways to work our way through that. We subtly but powerfully go about our business ensuring that we do not make real naked contact with the peak intensity of our own emotions. And I believe that this is most unfortunate because that type of intense contact is often necessary for emotional healing to take place. Not always, but it often is. Just very briefly about Arnold Beiser. He was an American doctor who, about 3 years after he qualified, he developed polio. About 3 months before the polio vaccine was invented, he developed polio. And he was paralysed by it. He got a very severe dose of it, and he ended up using an iron lung for most of his life. But he still managed to go ahead and become an award-winning psychiatrist. But I came across this a number of years ago, and I think it's an ingenious little piece of information. The paradoxical law, theory of change, he called it. Change occurs when one becomes what he or she is, not when he tries to become what he or she is not. Change does not take place through a coercive attempt by the individual or by another person to change him or her, but it does take place if one takes the time and effort to be what he or she is, to be fully invested in her or his current positions. By rejecting the role of change agent, we make meaningful and orderly change possible. And this is something I see regularly playing out as a truth, playing out in my work with people. I see it every day. For example, You know, if a person who has been holding much sadness, pain, loss, fear, and unfinished emotional business in them for years, they will generally make little progress with this, as long as they seek to deny that it is within them. Change can occur when the person accepts what is in them, feels it more fully, and is prepared to work through it with help and support, and come out the other side. The more a person tries to not be who and what they are, and what they have experienced, the more stuck they remain, generally. By accepting people where they are, by listening very respectfully to what people say and what they don't say, you, the Samaritans, facilitate people to be their own agents of change. It struck me that the need for and the importance of the Samaritans is proportional to the level of maturity of a society. A truly mature society would accept the validity of people's painful feelings and experiences. In such a society, people would have freedom to be all of who they are, to feel and express any aspect of the life experience that is real and has meaning for them, including their emotional pain, distress, feeling suicidal, all of which would be responded to appropriately and openly in a truly mature society. Unfortunately, most and perhaps all societies are not yet near that level of maturity. And as long as societies continue to censor people by censoring important aspects of people's life experiences and feelings and behaviours, then the Samaritans will continue to play a vital role. The degree of this vital role, as I said, mirrors the degree of censorship, which mirrors the degree of immaturity of a society. And since the current level of societal immaturity is quite considerable, in my opinion, in these areas, then the need for the Samaritans is indeed vital. So finally, I would say to you that in my opinion, you are doing profoundly important work. Profoundly important work. And the only bit of advice I would give you is keep doing what you're doing. Thanks very much.
If you want to ask a question, please just raise your hand, and Dermot and Victor will pop up to you with the mic to address the lecture. Here we go.
Morris from Athlone. When you spoke there about when a person wanted to make change, could you elaborate slightly on what tools you think that they would need to make this change?
Well, I suppose, Martin, is it?
Morris,
sorry. Morris, I think first of all, it depends on a number of things. I think that perhaps the most important starting point is, where is the person in themselves? For some people, my second book was called Selfhood, and the reason it was called Selfhood was that I had come to see that the person's level of self, in terms of their confidence and sense of empowerment, etc., is an enormously important factor in their confidence to make choices and make change. So I think when I'm working with someone in that type of situation, I try to support the person in, when a person is very scared of change, then the first thing to do is to hear that and respect where they're at. And then baby steps. Baby steps. A mountain can seem really, really impossible to climb, but it's climbed one step at a time. So I think, again, some of this comes back to listening, and that is to really hear where the person's at, what changes they're talking about, perhaps, or what changes they might need, what their fears are, some exploration, perhaps, of the reasons, although I know that might not come into Samaritans, but, are they making the changes to further avoid, or are they making the changes to try to address stuff? But I think the bottom line, really, and what I'm trying to say is that change is scary. And even recognizing that, and meeting the person where they're at, and honoring that fear, actually can diminish the fear itself, and the person can relax a little bit and be perhaps more open to looking at what they might need to do next. Does that make sense?
Dr. Lynch, can I thank you for your address, which was very affirming for us. You say that you hear a lot of words of praise for Samaritans.
Yes.
Do you ever hear any words of criticism something that we might learn?
Sure. I think I probably heard it once. And it was from someone who didn't feel listened to. Only once. And what they did was they rang again a few minutes later and talked to somebody who listened. Resourceful person that they were. But it was that again, it was that they felt not really listened to, and that the person was coming in too quickly with advice, and perhaps a little intolerant of what they were saying. This is about 3-4 years ago now. So the person did not feel heard, and then, as I said in my talk, that had certain effects. The person did not feel met at all. So that, and I think what Jenny was saying in terms of perhaps the Samaritans going out into the communities and making more of a presence. I think that sounds right to me as well, because what I said was how I feel, like that. The Samaritans are a very big force, and yet they are kind of out there somewhere, as I said. Where are they? Do people go into the Samaritans' offices? Not really. So I think there might be something there about grounding more visibly, and maybe Samaritans maybe the Samaritans are contributing to that a little bit by kind of not exactly going along with the kind of secret, if you like, but I think it would be a good idea for perhaps, and it's not for me to say, but to be more visible out there, if that makes sense. It might help to normalise for people what it is they're going through.
Antoinette from Cork. Dr. Terry Lynch, thank you very much. You've been very insightful. I've read Beyond Prozac and found it very helpful, even with taking calls in Samaritans. Can I ask you though, do you see psychiatric care and even GP care changing in the country with regards to mental illness?
Well, that's a big one. I think in ways there's a willingness to change, but on the ground I'm not sure if that is filtering through. There was a lot of talk in the media the other day about prescription rates for medication. It dominated the Examiner, I think, about 2 days ago, and it was in lots of media programs. I don't think things have really changed that much. I was on the expert group that created Vision for Change, and that was 2003 to 2006, so that's 9 years old now. And the majority of the recommendations of Vision have not been implemented. There's still a great shortage of therapists. So a lot of the core issues have not been addressed. But I do think there's a fundamental problem. I kind of touched on it when I didn't feel this was a place to go into it in much detail, but I do think that if we're to make progress in mental health, we've got to go back to basics. And the basics to me are, what actually are the problems? What's going on? And I've put a great deal of thought into this, and it does seem to me that the core issues are woundedness and trauma, the distress that woundedness and trauma causes, and how that's expressed in all its forms, the defense mechanisms that we humans create, and they can be very elaborate and very complicated, to protect ourselves from further woundedness and from our own pain, and then the choices we make that are influenced enormously by the previous three. I think that's where the research should go, and I can honestly say that, in my opinion, I'm not sure the mental profession can do that. I'm not sure the mental profession can honestly look at that and see the potential of that, because the medical profession is so trained in a particular way that with the best efforts they make, quite often, they just do not see, the majority do not see the immense importance of those issues I've just mentioned. So I think if I were to come down on one side, I would say no, I'm afraid. I think there is a willingness. I sometimes wonder, and again this is me, just me, I sometimes wonder if we're being led in mental health by the right group of people. I sometimes wonder if doctors have the knowledge and understanding that the public assumes that they have. And I'm not convinced that they do. That is not, by the way, to say for 1 second that medication has no role, or that anybody that's not it at all. I'm just saying that if we're to really resolve this whole mental health crisis that we have in the Western world, that we must take another look at the basics, because everything derives from the basics.
Hi, Mary from Drogheda here. This is as much an observation. It's as much of an observation as a question. You made reference earlier in your talk to people being stuck emotionally. We would have, as Samaritans, we would have quite a number of callers who appear to have been stuck for years, and they ring repeatedly and they tell their story again and again and again. And we wonder sometimes how we are helping them in any way. Have you any comments to make?
Yeah, sure. Well, I think, the proof is in the pudding, really. If they keep ringing, you're helping them. I mean, that's one answer. If they keep ringing, they're getting something from the call. They're being heard, they're being listened to. And in a way, that's one example of why I put free will in there. In the work I do with people, it's often struck me that we're all like sovereign states. Every human being is like a sovereign state with their own governing systems. And I don't have the right to intrude in somebody else's governing systems. And I think that's a very respectful way to approach people. So if somebody is ringing and is repeating the same story over and over, but if they keep doing it, then they're clearly getting something from it. But I think the listener doesn't have the right to force, and you don't anyway. The Samaritans don't give much advice. For many people, they're not ready, they're not able, or they're terrified of progressing beyond where they're at. And for many people, the society and the systems that are there don't hold them in that process of change. So my hunch is, if that's what seems to be what the person wants, to ring you and tell them this, and they got off the phone feeling better than they did when they rang you, you've achieved a lot. And I think realism is important. If the systems aren't there in our society, that's not it. That's not your fault, and it's not the listener, the ringer, the caller's fault either. You can only do what you can do, but you're doing a lot. Because ultimately, that person will have to become their own agent of change, and you can't push that or force it but it may be by the 55th call. The person may think, maybe I can progress this a little bit myself. That makes sense? Yeah.
I'm Terry, I'm a new volunteer with the Limerick branch. But one of the things that struck me in the listening is the amount of people that called us were very heavily medicated or intoxicated to some degree or other.
Yeah.
And I just wondered to myself, are they capable with that level of intoxication or doped up that they seem to be avoiding the very pain that they need to experience to change?
Are they capable of what?
Are they capable of change by us listening to them? Is that why they're kind of stuck in a cycle, that they can't change their behaviour because of the degree of medication that they're taking?
Yeah. Well, if you take alcohol first. Again, I've put a lot of thought into this over the years, and one of the things that alcohol does to people is it can often bring them to a place where they express something that is in them, but that if they weren't under the influence of alcohol, they wouldn't say. So when somebody rings you and they're intoxicated, and I'm not suggesting for 1 second that anybody would do that, but that's not to be dismissed, because they are actually often revealing truths in that place that they wouldn't reveal at other times. So there's nothing wrong with that at all. With regard to medication, well, I mean, medication helps in some ways, but it can hinder in some ways. That's true. And it can hinder people working through their emotional stuff. That is true. But in the society we live in, as I said, I think one has to be realistic about these things. A lot of people are on medication. There's not much you can do about it. I don't mean that in just a realistic way, it's the way it is. But they're still choosing to phone you. So they're valuing the phone call. And I think rather than perhaps worry or be downhearted about the fact that you feel that a person in this situation may not be able to change, maybe just take heart from the fact that they picked the phone up and rang. That itself took courage, and in that interaction for them something good has happened. Does that make sense? Yeah.
Maura from Limerick.
We actually have a question from the back there next. Victoria.
Here, Maura from Limerick. That was a very inspiring talk you gave us, Dr. Terry. I'm very grateful for it.
Where are you, Maura? I can't see you, sir.
It brings to mind
sorry.
something I heard a couple of years ago, not my words, but I love them. My truth may not be beautiful, but I am beautiful when I tell it. And you have been so affirming of us that I let my little bit on, and we are beautiful when we hear it.
Yes, absolutely. I mean, I over the years, I've had a lot of dealings with a lot of people and a lot of groups and a lot of organisations, but I think there's something special about the Samaritans. I mean, it's a great title, and I think it's very true to the original meaning of the word Samaritan. So yeah, you're absolutely right.
Giovanni from Bangor and Dairy Branches. It's a follow-up to a previous answer and questions that you've given. Very often we worry about callers becoming dependent on us.
Yeah.
So it's kind of related to perhaps the 55th call and so on. And I really do appreciate the answer you're given, but from a professional point of view, would you be concerned about somebody who seems, perhaps it's described as being stuck in a place, but worry about a dependency on an organisation like Samaritans or somebody else? You know, is that something that we really do have to take into account?
Yeah, it's a big question. I would know a number of people who, over the years, have wronged the Samaritans a lot. And I would know some people who I would kind of, on one hand, say to myself, well, they're not suicidal at all, really. They're ringing because they mightn't have anybody else to ring. And I sometimes, with one or two people I can think of, I at times I would say to myself, oh my God, I mean, because they would ring the Samaritans maybe 10 times a week or more. But again, I come back to realism, you know, and the type of society we live in. There are so few real supports for emotional and mental distress out there in our society. You know, a man cannot, or, you know, people can't, in a conversation, men cannot. I remember being very struck, and I mentioned this in Beyond Prozac, 15 years ago, and it was a British documentary on suicide. And they talked to a group of guys in a bar about one of their friends who had killed himself. And they were all shocked, and the interviewer, who was a woman, which might have been relevant, asked them, you know, what do you guys talk about? And he said, you talk about feelings, and the man said, oh God, no, we talk about football and, you know, all this stuff. And it just struck me so heavily. Where does a person in distress go? And, you know, with the best, you know, great respect to doctors and psychiatry, generally speaking, distress is dealt with by medication within that system, which both silences the distress, because the person doesn't get the time or the space to work it through, and it numbs the distress, because that's what medication basically numbs distress, which has of course it has an important part to play. So in terms of, it's a very long-winded way of answering your question, but while I have noticed it as something that happens, I have kind of come to the conclusion that it's better, I suppose, that the person over-rings the Samaritans than either kills themselves or is on lots of Valium or drinking very heavily. If it's going to be a dependency, it's a pretty healthy dependency. You know, it's not going to do them any harm, and they get a good response each time. They get a real response. I can understand how it might be something as an organisation to be looked at, but I am continuously struck by the lack of places people can go. Does that kind of answer your question?
Time for one more question from the back there.
Hi,
Dr. Terry, Helen from Limerick, thank you for a very inspiring talk. It was really enjoyable. Just one question coming back to you mentioned Vision for Change,
Yes.
which is a very powerful document.
Yes.
And I'm just wondering, what would you think would be the biggest change you would like to see from that, and would you like to see legislative change as well?
I think the biggest change I would like to see is that recovery should become central. It's not central. I'm not sure it ever will be central, but it should be. I and many others have been fighting to have it central as the core central approach of the mental health services for over 10 years. And we've met with resistance from many, many quarters. So I would like to see recovery as the core, and the person as well, obviously, as the core, and their own individual journey of recovery. Recovery is possible. Yesterday I talked to a guy who came to me. He's come to me for quite a number of years, but he's recovered. And we had a conversation actually about the Samaritans, because I told him I was speaking here today, and he said something very interesting. He said, a thought that I had myself actually. He said, one of the great things about the Samaritans is they've kind of stuck to what they do, and they do it very well. In other words, your brief hasn't expanded into a whole range of new things and trying to do them differently. But the interesting thing about him, he's completely recovered. He's off all medication for 7 years. He's living a full life. But he had a diagnosis, an appropriate diagnosis of paranoid schizophrenia. Now, out there in society, you're not supposed to recover from paranoid schizophrenia. But people can. And if people can recover, then common sense would suggest that we should be channeling a great deal of our research into people who have recovered to figure out how they did it so that we can help other people. And there are blocks in the system to that, very powerful, serious blocks. So that's a long-winded way of answering your question. Legislatively, yes, of course. I think it has to be supported by legislation, yes.
One last question.
Yeah, I think just time for one more, yeah.
Brian from Kerry. Just a kind of personal question.
The mic there, right?
Brian from Kerry.
Right.
A personal question to you.
Yeah.
What happened in your life, or what influenced you to make such a change from general practice to here?
Well, I didn't have the easiest of childhoods. I mentioned that beyond Prozac. I went through a fair bit of anxiety and loneliness, I suppose, in my teenage years. I think that probably helped me identify with people who went through similar stuff. But I think perhaps the best way to say it is like a commitment to truth. I kind of made a commitment to truth a long time ago. And I suppose I've taken a broader picture of this. I mean, the way I see it, this sounds very spiritual perhaps, I don't know. But to me, one of my most important days will be the day I die. And I will want to be able to look back and say to myself, I lived an honest life. And that became quite strong for me, I suppose, 20 years ago. And so an awful lot of what I do revolves around that commitment to truth. And that makes other things less important. Like it makes criticism, or like I've been relatively ostracized by my medical colleagues. That is of no concern to me, because pursuit of truth is the most important thing, in my opinion. So, but certainly my own experiences have because I could see it then in other people, and I kind of had a sense of what people are going through. Does that answer your question? Sure.
Definitely a very, very well-deserved round of applause for Dr. Terry Lynch. Thank you again, Dr. Lynch. Ladies and gentlemen, that's the end of the first session this morning. It's time to head off for tea and coffee break, which will be outside. Just a reminder, when you're actually going to the workshops, if you just know you should know right now the actual workshops that you're going to. And if you're in ballroom A or B, that's here. You'll actually be coming back here after the tea and coffee break, but we would ask everybody to actually vacate the room, because they need to actually partition it off and get it ready for the next couple of sessions. For those that are going to the Barrington Suite and the O'Brien Suite, they're over in the far over part of the building. Now the coffee break ends at 11:45, but I would ask you that you give yourself a good 5 minutes to get to the workshops to ensure that they all start on time. Okay? Thank you very much.